Welcome to the Deep Dive Ortho, where we take a close look at critical topics impacting medical professionals and patient care. Today, we're delving into an injury that, well, at first glance, it can seem deceptively simple, maybe even benign. Yet it holds this profound potential for truly devastating consequences. For the affected limb, and, in some rare and tragic cases, for life itself. We're talking about high pressure injection injuries. You might initially picture perhaps a small puncture wound, something from a stray nail or a sharp shard of metal. But I want you to imagine something far more insidious. A fluid, or perhaps a gas, under immense, unyielding pressure, violently forcing its way deep into the delicate, intricate structures of the hand, or actually any part of the body. This isn't just a simple cut, it's a clinical scenario that demands immediate recognition and decisive, often quite aggressive, action. It's almost like a ticking time bomb hidden just beneath the skin.
What's truly fascinating and frankly deeply concerning here is precisely that initial, almost innocuous appearance. It's the very thing that can lead both patients and, unfortunately, even some healthcare professionals to profoundly underestimate the rapid and extensive damage occurring just beneath the surface. This deep dive is really about stripping away that deception, understanding these hidden dangers, and outlining the absolute critical steps for optimal management. Because, well, the cost of underestimation is simply too high.
Absolutely. Today we'll be dissecting the etiology, so where these injuries actually come from, the our devastating pathophysiology, the crucial steps for accurate diagnosis, and most importantly, the urgent emergency management of these injuries. We'll be drawing upon the collective understanding and the latest insights from the orthopedic enhanced surgery communities. So what does all of this mean for you, whether you're encountering a patient perhaps in an emergency department, maybe an occupational health setting, or even preparing for surgery in a theater? Let's unpack this and get to the core of what you need to know. Aye, boy. The deceptive nature of high-pressure injection injuries. So to begin, what exactly defines a high-pressure injection injury and what makes it so uniquely problematic and, well, frankly, terrifying, despite its often benign initial presentation?
Well, fundamentally, it's the breach of the skin by a fluid or a gas under significant pressure. The reason it's so problematic lies in a critical, often quite counterintuitive fact. The threshold pressure required to breach human dermis is remarkably low.
Really? How low are we talking?
We're talking about just 100 pounds per square inch, or CSI.
Just 100 psi. Okay.
Exactly. To put that into perspective for our listeners, many common household tools are more than capable of inflicting such an injury. Think of a standard pressure washer, for
All
example.
right, the kind you might use on the patio.
Precisely. Which typically operates somewhere between 1,500 to 4,000 psi, so
Yeah.
many multiples above that dermal threshold. Now, elevate that to industrial settings. Tools like paint guns, grease guns, hydraulic hoses. These can generate pressure soaring up to, well, 10,000 psi.
That's a staggering amount of force. When you say 10,000 psi, can you help us visualize that kind of power? It's hard to grasp.
It is. This immense force is truly astonishing. Imagine the equivalent of 1,000 kilograms, that's a metric ton, suddenly falling 25 centimeters onto a single digit.
Wow.
That's the kind of blunt trauma equivalent, the sheer kinetic energy we're talking about with these high-pressure systems. That's why the term invisible liquid bullet is so often used, and quite accurately, I think.
Invisible liquid bullet.
Yes, because the entry wound itself can be deceptively small, often no more than maybe 1 to 7 millimeters in diameter. It might appear initially as nothing more than a tiny red spot, perhaps a pinprick. Yet beneath that seemingly harmless surface, the injected material rapidly penetrates deep into the subcutaneous fat, tearing through delicate soft tissues, rupturing blood vessels, and destroying nerves almost instantly. This initial benign presentation, this invisible entry, is precisely what makes these injuries so dangerous and frequently leads to their profound underestimation by both patients and, at times, unsuspecting clinicians.
That's a striking comparison, an invisible liquid bullet creating that kind of internal devastation. So what are the typical scenarios where these injuries occur and who is most commonly affected in your experience?
Well, these injuries are almost exclusively occupational. The research consistently shows that a staggering 99% of those affected are male manual workers.
99%. That's overwhelming.
It is. The etiology is typically accidental contact with high-pressure equipment. A very common scenario involves, say, cleaning the nozzle of a high-pressure spray gun where it misfires unexpectedly, or direct skin contact with a high-pressure leak in piping, or a hose. What's crucial to understand here is that with these incredibly powerful systems, direct nozzle-to-skin contact isn't even always necessary to sustain an injury.
Really? So just being close is enough?
Yes, the sheer force of the jet can cause penetration even at a distance in some cases.
Okay. And which body parts are most vulnerable then?
Precisely. The most frequently affected area is consistently the non-dominant index finger.
Ah, often used for fiddly jobs, perhaps.
Exactly. It's often because it's instinctively used to clear a blocked nozzle,
Hmm.
maybe to stabilize objects near the spray, or even to test a system. Other common sites include the thumb and the palm. However, injuries can occur anywhere on the extremities, and in rare, more severe cases, high-pressure injection injuries have even been reported in the face, neck, spinal cord, thorax, and even the perineum. It really highlights the far-reaching and indiscriminate potential of these incidents.
Gosh, that's quite a range.
It is. And in terms of causation, inattention, misuse of equipment, or material failure are consistently identified as the main contributing circumstances. It's often not a lack of experience, interestingly.
Right, so even experienced workers can be caught out.
Absolutely. Even highly experienced workers, intimately familiar with their tools, can suffer these devastating injuries if their attention wavers for just a moment. In terms of overall incidence, high-pressure injection injuries account for approximately 1 in every 600 hand traumas presenting to the emergency department.
So relatively rare overall.
Seemingly rare, yes. An average trauma center might see, say, 1 to 4 cases per year. But their potential for severe, life-altering morbidity makes them highly significant and absolutely critical for any medical professional to recognize immediately. 2. The devastating pathophysiology.
Having understood that deceptive entry and the incredible force involved, let's now peel back the layers and truly grasp the destructive processes unleashed beneath the skin. Once that fluid penetrates, what are the primary mechanisms that lead to such profound tissue damage and morbidity? It's clearly not just a simple puncture, is it?
You're absolutely right. It's far more complex. And this raises an important question, because understanding these mechanisms is crucial for appreciating the real urgency of treatment. The injury process unfolds through a destructive cascade involving 3 primary mechanisms, really. Each one compounds the damage and accelerates the progression towards, well, potentially devastating outcomes. First, we have the direct mechanical impact and the compressive effects. The sheer force of the high-pressure injection physically tears and lacerates ligaments, tendons, critical neurovascular structures, just rips through them.
Just the force itself.
Just the force. The injected material, or even air, then rapidly flows along paths of least resistance, often tracking along and around neurovascular bundles. And what's truly alarming is how proximally this material can spread. We've seen it reach the forearm, or even the upper arm, and in the most extreme, horrifying cases, it can actually track into the mediastinum, behind the sternum.
Into the chest cavity.
Yes, leading to potentially life-threatening complications.
So the fluid literally dissects its way through the body, tearing as it goes.
Exactly. And the uncompressible fluid, even in relatively small volumes, within the confined anatomical spaces of the hand and forearm, rapidly increases pressure. This leads to profound ischemia, a lack of blood supply, venous occlusion, and thrombosis, blood clots forming. This is entirely analogous to an acute compartment syndrome, but one that can develop within minutes or hours rather than the days you might see with, say, a fracture. The speed is critical here.
Right, much faster onset.
Much faster. Seminal cadaveric studies, like those by Kaufman back in the 1970s, clearly illustrate these fluid pathways. For instance, injections occurring over thick annular pulleys in the finger tend to encircle the digit and neurovascular structures subcutaneously, just under the skin. However, if the injection occurs over thinner cruciate pulleys, perhaps at the joints, the fluid can breach directly into the flexor tendon sheath, that's the lubricated tunnel for the tendons. And at very high pressures, it can even enter the joint itself, potentially leading to septic arthritis down the line. Furthermore, paramidline injections can spread to the dorsum, the back of the hand, and along the dorsal spaces. And remember, injections into the thumb or little finger tendon sheaths are more likely to involve the forearm.
Ah, because of the connections.
Exactly, due to their direct connections with the radial and ulnar bursae, those fluid-filled sacs that help reduce friction in the wrist and hand. Similarly, injections into the volar palm can contaminate the interosseous muscle spaces, the palmar arch, condylar nerves, and extend to the dorsal spaces of the hand. This widespread dissection, often following existing anatomical planes, is a key component of the devastating mechanical injury.
It's incredible to think how a tiny entry point can lead to such widespread physical disruption and a rapidly developing compartment syndrome. That paints a vivid picture of the internal trauma.
What about the chemical side of things? You mentioned fluid type matters. Yes, and that's the second crucial mechanism, chemical toxicity. And this is, arguably, the most significant determinant of the patient's prognosis.
More than the pressure itself?
Often, yes. Different substances elicit widely varied inflammatory and cytotoxic responses, directly impacting the severity of tissue damage and, crucially, the likelihood of amputation. For instance, organic solvents like turpentine, diesel fuel, jet fuel, and certain types of paint, especially oil-based or solvent-based varieties, are profoundly destructive.
How destructive.
These substances cause a rapid liquefaction of tissues, essentially dissolving them, and they trigger an incredibly robust inflammatory response, often leading to a chemical burn deep within the tissues. Amputation rates for solvent-based paints can be as high as 80%,
90%.
and
Wow.
for oil-based paints or hydrocarbons, around 70%. These are truly devastating figures, indicating that limb salvage in these cases is often the exception rather than the rule.
That's incredibly stark. And what about other substances like grease? Is that less severe?
It is generally less severe, yes. Substances like grease and wax, while certainly space-occupying and damaging due to the pressure effects, don't trigger as immediate or aggressive a cytotoxic effect. Instead, they are typically engulfed by the body's granulation tissue over time. This leads to the formation of chronic granulomas, a type of inflammatory nodule, and potentially persistent discharging sinuses weeks or even months later.
So a more chronic problem develops.
A more chronic inflammatory problem. The amputation rate for grease is notably lower, around 20%, though still significant, obviously. And then at the milder end of the spectrum, we have air and water injections. These generally have the best prognosis as they are absorbed by the body over time and usually bypass this aggressive, destructive chemical phase.
But still not harmless.
Definitely not harmless. Even water, due to the sheer mechanical pressure, can cause significant morbidity. Things like flexural tenosynovitis, acute compartment syndrome, and in some cases, water injections can still lead to amputation, although typically less than 20% of the time. So the fluid's chemical composition plays a pivotal role in dictating the long-term outcome, sometimes even more so than the initial pressure.
It's incredible how the substance itself dictates so much of the destructive potential, from almost immediate liquefaction with solvents to those chronic granulomas with grease. And the third mechanism in this destructive cascade.
The third phase is secondary microbial infection. Now, this varies widely in reported frequency. Some studies say as low as 1.6%, others as high as 60%. But this phase could certainly intensify necrosis and further complicate the clinical picture.
So the injected stuff isn't always infected itself.
Correct. It's important to note that most injected materials don't directly support bacterial growth. However, contamination can readily occur from the environment where the injury happened. The dirty workshop floor, for example, or from the patient's own skin flora, which is never sterile. When infections are present, they are often polymicrobial, involving multiple types of bacteria, or predominantly gram-negative organisms, which can be particularly virulent and harder to treat.
Right.
Due to this significant and often unpredictable risk, empiric broad-spectrum antibiotics, covering both gram-negative and gram-positive bacteria, are strongly advocated immediately upon presentation, even before surgery.
Just assume contamination.
Pretty much. It's also worth mentioning that some organic solvents may actually inhibit bacterial growth, which sounds good, but can sometimes complicate the clinical presentation by masking an infection that might otherwise be more apparent, potentially leading to a false sense of security. Ultimately, the necrotic tissue created by the initial mechanical and chemical insult serves as an excellent culture medium for bacteria if they are introduced, allowing them to proliferate rapidly if treatment is delayed.
So the initial pressure dictates the immediate, widespread mechanical spread. The substance determines the severity of the chemical assault, and then infection can compound it all. It's a truly complex and rapidly unfolding interplay of devastating factors, each capable of causing profound, permanent damage. 3. Diagnosis and initial assessment, the crucial first hours. Given the potentially devastating consequences you've just outlined, timely and accurate diagnosis is absolutely critical. But it seems, as you said, patients and even some clinicians can be initially misled by that benign appearance. What should we, as medical professionals, be actively looking for to avoid this dangerous pitfall?
Precisely. The core challenge in managing these injuries lies squarely in their deceptive initial presentation. We often see patients arrive directly from an industrial site complaining of what they perceive as just a sting, maybe a minor abrasion or insignificant pain. And they've got this small, innocuous puncture wound, perhaps no bigger than a needle stick.
It's like nothing much.
Exactly. And this benign appearance is profoundly dangerous. Studies tragically indicate that patients may consult several physicians, sometimes even receiving minor wound care and being discharged, leading to an average diagnostic delay of 9 hours before a correct diagnosis is obtained.
9 hours, wow.
9 hours. During this absolutely crucial diagnostic delay, the true hidden damage progresses relentlessly and irreversibly, often leading to neurovascular compromise, escalating edema, and a rapidly developing compartment syndrome. Therefore, history is absolutely paramount. This is your first and most critical diagnostic tool. You need to elicit a detailed, meticulous account from the patient.
What specific things do we need to ask?
The exact time of injury. The precise mechanism, how did it happen? Was it a misfire, a leak, a cleaning action? The specific tools involved, the chemical injected, and if possible, immediately obtain its material safety data sheet, the MSDS.
Right, get that data sheet.
Absolutely. Yeah. It provides crucial information on composition and toxicity. Furthermore, inquire about the pressure magnitude of the injection tool if they know it. This information is key, as it helps you understand the potential extent of the zone of injury, which, as we've discussed, can extend far beyond the tiny entry site, from the fingertip up to the forearm, upper arm, potentially even the mediastinum. For instance, knowing if the paint was titanium white, which is radiopaque, versus a clear solvent, dramatically impact what you'll expect to see on imaging later.
Got it. So history first, then the examination.
Then a meticulous physical examination is imperative. And this isn't just about the hand. A thorough assessment of the entire extremity hand, forearm, elbow, upper arm, and axilla is critical to assess for any proximal extension of the injected material. You must diligently look for subtle signs. Any skin discoloration, assess peripheral pulses to gauge vascular integrity, and perform a complete neurological assessment to detect early nerve compromise. Look for changes in sensation or motor function. Critically, serial examinations of the anatomical compartments are essential.
Serial exams. How often?
Frequently, because compartment syndrome can manifest hours after the injury due to progressive inflammation and edema. Any clinical signs of rubor, redness, calor heat, dolor, pain disproportionate to the superficial injury, especially on passive stretch, and functional impairment should immediately raise a high index of suspicion, prompting urgent action. Remember, only about 1 in 4 patients initially present directly to an emergency department for these injuries.
Only 1 in 4, so others might go elsewhere first.
It's exactly. Maybe to a GP or an urgent care center. This makes the early clinical suspicion and a thorough, systematic approach even more vital for the first clinician to see them.
It's clear that a high index of suspicion, driven by a detailed history and repeated physical exams, is absolutely non-negotiable. What role does imaging play in this acute phase? Can it confirm the diagnosis?
And finally, imaging plays a supportive but often crucial role. Plain radiographs are essential immediately.
X-rays first.
Yes, X-rays first. They will clearly define the spread if the substance is radiopaque, like that titanium white paint I mentioned. We've observed this vividly in cases where radiopaque paint has tracked along subcutaneous planes and around neurovascular bundles, providing a sort of roadmap for the surgeon. For radiolucent materials, such as air or water, you might still see evidence of subcutaneous emphysema on the X-ray, indicating air injection.
Okay, so X-rays are useful. What about CT or MRI?
Well, advanced imaging like CT and MRI can indeed help assess the precise extent of soft tissue damage. They can provide valuable insights into fluid tracking around neurovascular bundles, into interosseous muscle spaces, or the palmar arch. However, they are generally not necessary for the initial diagnosis that drives emergent management.
So don't delay surgery for a scan.
Absolutely not. The clinical picture, combined with the detailed history and physical exam, should always dictate immediate surgical consultation. We wouldn't delay transfer to a surgical center or the operating theater just to get an MRI. That said, they can be invaluable in the perioperative period for assessing the full extent of the injury, particularly if the initial debridement seems incomplete or if there's an unusual pattern of spread. For example, a CT might reveal mediastinal involvement that wouldn't be apparent clinically, but for the initial decision, clinical assessment is king. Fourth, emergency management, a surgical urgency.
This leads us directly to management. If early diagnosis is the first hurdle, then prompt, decisive intervention is certainly the next. What's the immediate protocol for a high-pressure injection injury, given its true emergency status and that ticking clock you mentioned earlier?
Indeed. Let me be absolutely clear. This is unequivocally a true surgical emergency. There's really no two ways about it.
No waiting around?
None whatsoever. Prompt surgical consultation and intervention are non-negotiable for the vast majority of cases. Clinical research consistently indicates that patients treated properly within 10 hours of injury and ideally within 6 hours experience significantly better outcomes with substantially lower amputation rates.
6 hours, that's the magic number.
6 hours is the ideal window we aim for. Some studies show a dramatically higher rate of amputation, approaching 50% for finger injuries, when initial debridement takes place after 6 hours. The evidence is unequivocal. The sooner the definitive surgical debridement, the better the outcome for limb salvage and functional recovery. And the clock starts ticking the moment the injury occurs, not when the patient arrives at your door.
Right. Okay, so what are the immediate medical steps before they even get to theater?
Let's break down the initial medical treatment steps, which are vital and should begin immediately. First, immediate transport to a hospital with established surgical capabilities, particularly hand and upper limb surgery expertise, is vital. Time is tissue. Once the patient arrives, tetanus prophylaxis should be administered if indicated. These are inherently contaminated wounds, often occurring in industrial environments.
Makes sense. Antibiotics too.
Crucially, yes. Intravenous broad-spectrum antibiotics providing comprehensive coverage for both gram-negative and gram-positive bacteria are essential to prevent secondary infection. Remember to take wound cultures during the surgical debridement to guide any necessary adjustments to later antibiotic therapy. The affected limb should be immediately elevated to help manage swelling. Gravity will help reduce edema.
Elevation, okay. Ice.
No, critically, avoid cooling packs or ice. These can further compromise tissue perfusion by inducing vasoconstriction, potentially worsening ischemia in already compromised tissues. Keep the limb at a warm physiological temperature.
Right, no ice. Good point. Dressings.
Furthermore, you must not use compressive dressings or attempt to close the wound, even temporarily. These injuries swell significantly, and any compression will just exacerbate compartment pressures, accelerating the onset of compartment syndrome. Leave it open. Finally, a key point for anesthesia. Absolutely avoid digital or local blocks at the injury site.
Why no local blocks? Seems counterintuitive for pain.
Because they can contribute to local tissue edema and are associated with worse outcomes. They can potentially increase local tissue pressure and, importantly, mask the symptoms of a developing compartment syndrome. General anesthesia, or an axillary block, is the preferred approach for surgery, providing excellent analgesia without compromising the limb locally.
That's a comprehensive, immediate response, laying the groundwork. Now, turning to the operating theater itself, what are the fundamental surgical principles for managing these incredibly complex injuries?
Right, the cornerstone of management is emergent surgical debridement. This is where the definitive treatment takes place, and it often requires significant planning and a high degree of precision. Firstly, wide surgical exploration is paramount. That small entry wound is entirely misleading. Incisions, like Brunner-Palmar digital or mid-axial incisions, these are standard incisions providing wide access, often along the side of the finger, must provide full and unhindered exposure to the entire zone of injury.
So, big incisions are needed.
Often, yes. This means extending the incision far beyond what appears to be the affected area, following the likely path of the injected fluid, which, as we know, can extend surprising distances. The goal is complete visualization. Secondly, meticulous decompression of all tissue compartments and careful exploration and incision of tendon sheaths are critical. The high-pressure fluid creates immense internal pressure. Releasing this pressure is vital for tissue viability. It's worth noting that while all compartments must be assessed, flexor tendon sheaths are often less involved than the surrounding subcutaneous tissues and muscle compartments, but they must still be explored if suspicion is high.
Okay, open everything up, release the pressure. Then what?
Thirdly, thorough debridement is essential. All injected material and any non-viable tissue must be meticulously excised. This can be particularly challenging with clear or lipophilic solvents, which are difficult to see within the tissue.
How do you know what to remove if it's clear?
Surgeons often rely on subtle changes in tissue texture, color, perhaps even smell, to identify contaminated or non-viable tissue. The goal is to remove as much foreign body as possible, balancing this with the need to preserve viable tissue and function. It's a delicate balance. Following debridement, high-volume saline irrigation is indispensable. Copious lavage with normal saline is essential to wash out any remaining contaminants and debris that couldn't be excised. Just liters and liters of washout.
Lots of fluid. Any additives?
There is some debate about adding povidone iodine 10% for specific contaminants like latex or oil-based paints, as some cadaveric studies have shown it can aid removal. However, if used, it should always be followed by copious saline irrigation to dilute and remove any microbes or chemical irritants, as povidone iodine itself can be cytotoxic if left in high concentration. So watch it out thoroughly afterwards. Finally, repeat debridement is common practice and often necessary.
So one operation might not be enough.
Often not. It's usually best clinical practice to leave the wound open after the initial debridement and plan for a second look operative irrigation and debridement within 24 to 72 hours, or until all devitalized tissue and injected material are confirmed to be removed. Sometimes a third or even fourth look is required. This staged approach allows for clearer demarcation of viable tissue over time.
And what about things like steroids? Do they help with the inflammation?
Regarding adjunctive treatments, the use of steroids, such as intravenous hydrocortisone, maybe 100 milligrams every 6 hours, tapered orally to reduce inflammation, remains controversial.
Controversial, why?
Well, while some advocate for their anti-inflammatory effects in severe cases, more robust evidence is needed, particularly concerning the theoretical increased risk of bacterial superinfection in what is already a contaminated field. The jury is still out on routine steroid use, and it should really be considered on a case-by-case basis with caution.
It sounds like an extremely aggressive, thorough, and iterative surgical process, often requiring multiple trips to the theater. Are there any rare circumstances where non-surgical treatment might be considered, or is it always, truly always, a surgical emergency?
That's an excellent question, and it speaks to the nuances. Yes, but these are very specific and limited cases. Non-surgical treatment with extremely close observation can only be considered in particular rare instances,
Such as?
such as injections of air, maybe water, or certain high-pressure veterinary vaccines. These substances are generally less toxic, are absorbed by the body over time, and usually bypass that severe destructive chemical phase we see with industrial materials. However, even in these instances, surgical decompression and debridement would be reserved for if a resultant compartment syndrome develops or if secondary infection occurs. This necessitates frequent compartment checks and extremely close, vigilant follow-up. You cannot just send them home.
So it still requires very close watching.
Very close. In fact, our own clinical experience, and that of many leading hand surgeons, suggests that even water-based paint and vaccination injuries should probably be taken to theater as an emergency for initial exploration and washout, rather than waiting for symptoms to manifest. The potential for serious complications is still there. The risk of waiting often outweighs the benefit of avoiding surgery.
So even for these milder substances, the default is still surgical exploration unless there's an overwhelming reason not to, and then only with extremely close monitoring.
Exactly. And ultimately, for severe injuries, especially those involving highly toxic substances like paint or turpentine, early amputation must be considered.
That's a tough decision.
It is. If the digit is cool, poorly perfused, or if the extent of damage makes salvage unlikely or would result in a non-functional limb, amputation might be the best option for the patient's overall function. This is a critical, often heartbreaking decision involving careful clinical discretion and thorough, empathetic discussion with the patient and their family. The goal is always the best possible long-term functional outcome, which sometimes means making difficult choices early. Prognosis, complications, and long-term outcomes.
So despite such aggressive and timely intervention, what factors ultimately determine the patient's prognosis, and what are the potential long-term complications they face? This really connects back to the patient's future and quality of life, doesn't it?
That's right. If we connect this to the bigger picture, the prognosis hinges on several critical variables. This is truly where the early decisions we make, particularly in that acute phase, profoundly impact a patient's future function and their quality of life. The time to debridement is, in fact, the only factor healthcare professionals can directly influence. And it's overwhelmingly the most crucial.
The only one we control.
The only one we control directly. As we've emphasized, delays beyond 6 hours and certainly beyond 10 hours significantly increase morbidity and, critically, amputation rates. Studies have shown a direct correlation. The sooner the debridement, especially for cytotoxic materials, the better the outcome. This underscores the paramount importance of immediate surgical intervention. A delay of just a few hours can genuinely mean the difference between a functional hand and a non-salvageable limb. The composition of the injected material is arguably the most important underlying factor in determining the overall prognosis.
Right, the chemical toxicity again.
Exactly. As we discussed, organic solvents like turpentine and oil-based paints are profoundly destructive, carrying amputation rates as high as 80%. They induce rapid tissue necrosis and an intense inflammatory response. In stark contrast, grease injections lead to amputation in about 20% of cases, while air and water injections have a much better prognosis, with amputation rates typically much lower, often below 20%, due to their non-cytotoxic properties. The specific chemical blueprint really dictates the tissue's fate. Then there's the force of injection. Higher pressures invariably lead to more severe soft tissue trauma and a wider, more rapid distribution of the injected material throughout the anatomical planes.
Pressure equals spread and damage.
Precisely. Research indicates a dramatic increase in amputation risk with rising pressure. For instance, pressures over 7,000 psi are associated with amputation rates of a staggering 95% to 100%.
95 to 100%, so almost certainly amputation.
Pretty much limb-losing injuries from the outset at those pressures. Even pressures between 1,000 to 7,000 psi show a high amputation rate of 43%, whereas injuries sustained at less than 1,000 psi have a comparatively lower rate, maybe around 19%. This kinetic energy can be enormous. Some high-pressure systems deliver liters of fluid per second, meaning even a fraction of a second of injection can deliver a significant volume of fluid into the tissue, creating immense pressure and widespread dissection.
And volume itself matters too, I imagine.
Yes, the volume injected directly correlates with morbidity. Larger volumes create more pressure on tissues, rapidly increasing ischemia. Even a small volume can be devastating in a confined space like a finger. Industrial systems, as I mentioned, can deliver liters per second, meaning even a fraction of a second can inject a significant volume, pushing past fascial barriers and causing expensive damage. Finally, the location of injury significantly impacts the prognosis. Finger injections, particularly those to the index finger, carry a higher risk of amputation, up to 6-fold higher than injuries to the palm or thumb.
Why the index finger particularly?
It's likely due to the smaller, more confined fascial compartments in the digits. These allow even smaller volumes of injected material to quickly cause compartment syndrome. Moreover, injections into the thumb or little finger tendon sheaths are more prone to involving the forearm due to those direct connections with the radial and ulnar bursae we talked about, meaning the injury can extend much further proximally than it initially appears.
That paints a stark and frankly sobering picture of the challenges, even with prompt and aggressive care. What are the common complications and, crucially, the functional outlook for these patients? Knowing all these interacting factors, what are they left dealing with?
The complications are extensive and often profoundly long-lasting, underscoring the severity of these injuries. Even with prompt and aggressive treatment, a significant percentage of patients experience severe sequelae, impacting their daily lives and their ability to return to work. Firstly, amputation remains a very real threat. Overall, amputation rates can approach maybe 28% to 40% across all types of injections. But for injuries involving highly toxic substances, this figure can soar to 50% or even 80%, as we discussed. It highlights the immense destructive power of certain chemicals. We've seen patients whose limbs, despite every effort, simply could not be salvaged.
And even if the limb is saved?
Even if the limb is saved, there's often significant loss of function. This includes a substantial decrease in range of motion, particularly in the critical proximal and distal interphalangeal joints, the finger joints. We see average decreases reported of around 24% and 30% respectively. Patients also experience significantly reduced grip strength, maybe an average 12% decrease, and a more pronounced reduction in pinch strength, averaging a 35% decrease.
That's a big hit to hand function.
Huge. Extensive fibrosis and scarring, which are common after the intense chemical and mechanical tissue destruction, frequently lead to severe contractures. This further limits the function of the affected limb or digit and requires prolonged, often difficult rehabilitation. Imagine the challenge of performing everyday tasks like opening a jar or buttoning a shirt with such limitations.
It sounds incredibly tough long-term. What about pain?
Yes, patients commonly report persistent chronic pain and sensory issues. This includes debilitating cold intolerance, where the hand becomes extremely painful in cold weather, persistent hypersensitivity to touch, and paresthesias, tingling, or numbness. These can be highly debilitating and significantly impact their quality of life. Neuropathic pain can specifically occur due to the direct effects of solvents on nerve membranes, creating persistent burning pain that is notoriously difficult to manage. Two-point discrimination, a critical measure of fine sensory perception, can be significantly impaired. Studies show an average increase of nearly 50%, indicating a substantial reduction in fine touch and dexterity.
An infection is still a risk later on.
While some injected materials may not directly support bacterial growth, infection remains a critical risk, especially with delayed treatment, as necrotic tissue serves as an ideal culture medium. We've seen cases where seemingly controlled injuries became complicated by aggressive, deep-seated infections days or weeks later. And if injected fluid is not completely removed during initial debridement, granulomas can form.
Those inflammatory nodules you mentioned?
Exactly. These chronic inflammatory granulomas can develop weeks or months post-injury, sometimes leading to persistent draining sinuses, discomfort, and ongoing inflammatory processes, often requiring further surgical intervention down the track. Finally, and this is a profound societal and personal impact, the impact on work is significant. Long-term follow-up studies reveal that only around 43% of patients successfully return to their previous employment.
Less than half return to their old job.
Less than half. This highlights the immense repercussions these injuries have on a patient's functional reintegration into the workforce, their financial stability, and their overall quality of life. It's a stark reminder of why prevention and rapid, effective treatment are so vital, not just for the limb, but for the entire individual. 6. The interprofessional team and prevention.
It's clear this is an incredibly complex injury requiring a truly multifaceted approach, far beyond the scope of a single specialty or clinician. What's the indispensable role of the interprofessional team in optimizing patient outcomes in these cases? And how can we foster that collaboration effectively?
That's a crucial question, because you're right, no single specialist can effectively manage these injuries in isolation. Enhancing healthcare team outcomes through a coordinated interprofessional approach is absolutely paramount. It's like a relay race, really, where every handoff needs to be seamless. First, emergency department clinicians are the critical first line of defense. They need to maintain an exceptionally high index of suspicion because of that deceptive initial appearance.
They're the gatekeepers.
Exactly. Their prompt actions, including giving those empiric broad-spectrum antibiotics and tetanus prophylaxis, are crucial for mitigating early complications and initiating the correct pathway. Their quick and accurate assessment can literally save a limb. Next, hand and upper limb surgeons are the primary treating specialists. Their expertise is indispensable for the complex surgical debridements, often requiring multiple procedures to meticulously clear all devitalized tissue and foreign material. The intricacies of hand anatomy and the need for meticulous dissection demand highly specialized skills.
Right, the surgical experts.
Then infectious disease specialists are critical for co-management, especially if wound cultures come back positive or if there are ongoing infection concerns. They provide invaluable guidance on optimizing antibiotic therapy based on specific bugs, helping to combat persistent or resistant infections that can really complicate recovery. A consultation with toxicologists can significantly enhance our understanding of the local and systemic effects of the injected substance, particularly for highly toxic materials where specific antidotes or systemic management might be required.
So they help understand the chemical involved.
Precisely. They can inform both surgical and medical management, helping us understand the long-term chemical implications beyond the immediate trauma. Nursing staff play an essential continuous role. Close perioperative monitoring, meticulous wound care, and crucial patient education to prevent complications like compartment syndrome or superinfection in those critical hours and days post-surgery. Their vigilance is absolutely key to detecting early signs of deterioration.
Can't do it without the nurses.
Absolutely not. And of course, physical and occupational therapists play an indispensable role postoperatively. Their early and aggressive intervention is vital in preventing contractures, maximizing range of motion, and enabling the patient's return to activities of daily living.
Getting them moving again.
Literally helping them to regain the use of their hand. They guide patients through exercises, splinting, functional retraining. And if amputation occurs, they're also fundamental to prosthetic training and rehabilitation, helping patients adapt to profound life changes. Ultimately, open, continuous, and clear interprofessional communication among all these providers is critical to limiting morbidity and achieving the best possible functional outcome for the patient. Without a truly collaborative team, outcomes will inevitably suffer.
That truly highlights the immense collaborative effort required, extending far beyond the operating theater. It really does take a village, as they say. But ultimately, the best treatment is always prevention. What key messages should workers and employers take away regarding these hazards to prevent these devastating injuries from happening in the first place? Because the statistics you shared on long-term disability are just heartbreaking.
Absolutely. Prevention is paramount. Education is truly the first and most effective defense against these injuries. Workers operating high-pressure equipment, whether professionally in an industrial setting or privately at home for DIY projects, must be thoroughly educated on the severe and often hidden risks. The first message is awareness and attentiveness. Workers must be highly attentive and focused, especially when cleaning devices, clearing blockages, or handling high-pressure lines, as this is a common time for injury due to misfires or leaks. Complacency kills.
Don't get distracted.
Exactly.
Yeah.
Secondly, and perhaps most crucially for workers, is immediate action. Despite the deceptively benign appearance that tiny puncture wound or just a stinging sensation, treat any such incident from high-pressure equipment as a severe injury.
Don't ignore it.
Do not wait. Immediately seek medical care from the nearest hospital with a surgeon on staff who can properly evaluate such injuries. It is vital not to treat it as a simple cut or minor injury. The consequences of delay, as we've discussed, are catastrophic. Be prepared to tell the medical team exactly what happened, the substance, the pressure if known. That information is gold.
And for employers, what's their responsibility?
For employers, workplace safety must be a non-negotiable priority. Companies must conduct thorough risk assessments to identify all pressure equipment hazards. Implementing robust, safe systems of work, such as permit-to-work systems that mandate depressurizing equipment before any maintenance, and establishing physical barriers or guards to prevent accidental contact are vital. Appointing specifically trained and competent personnel to operate and maintain this equipment is also key. Personal protective equipment, PPE, is non-negotiable and must be rigorously enforced.
The right gear is essential.
Absolutely. Appropriate PPE, including heavy-duty waterproof gloves designed for chemical resistance and puncture protection. Comprehensive eye and face protection, a full face shield, is absolutely essential for pressures above 2,000 psi. As I mentioned, a water jet at 4,000 psi can literally tear an eyeball from its socket.
Gosh.
Protective overalls, robust foot protection, all must be provided and consistently used. This isn't optional, it's life-saving. Workers should also perform dynamic risk assessment. No two jobs are exactly the same. Workers should continually assess risks before, during, and after a work activity, considering factors like weather, temperature, even their own individual approach and fatigue levels. If something feels unsafe, stop. The ultimate mantra for everyone involved should always be zero incidents, zero harm, zero compromise. This holistic approach, from individual worker awareness to comprehensive employer safety protocols and immediate decisive medical response, is the only way to truly mitigate the devastating impact of high-pressure injection injuries.
That was a truly insightful and profoundly important deep dive into high-pressure injection injuries. From understanding that counterintuitive physics of penetration and the devastating chemical and mechanical damage they inflict, to the critical importance of early surgical intervention and a coordinated interprofessional team. Well, it's clear that these seemingly minor incidents are true, limb-threatening, and sometimes life-threatening surgical emergencies, with significant and often permanent long-term implications for our patients.
Indeed. I think the single most important takeaway for anyone in the medical profession is to maintain an exceptionally high index of suspicion, to recognize the profound potential severity of these injuries right from the outset, and to understand that prompt, aggressive debridement, ideally within those 6 hours, is the key determinant in preventing limb loss and maximizing functional recovery. The cost of underestimation for the patient is simply too high to contemplate.
A crucial message for all of us in healthcare. And for you, our listener, we hope this deep dive has provided invaluable, actionable insights into a critical and often underestimated orthopedic emergency. As you reflect on this, perhaps consider how often a minor workplace incident might be hiding a catastrophic underlying injury. Are we, as clinicians, truly asking the right questions every single time? Something to think about. If you found this deep dive valuable, please do take a moment to rate and share the Deep Dive Ortho with your colleagues. It really helps us reach more medical professionals like you. Thank you for joining us on the Deep Dive. Until next time, stay well informed and curious.